In this episode, I talked to Professor Jill Cook about tendons. What is a tendinopathy? How to treat tendon pain based on the latest research? These are all questions that Jill and I talk about, and she really dives into. Jill is truly at the forefront in the tendon world. We primarily talked about tendons of the lower body. These include the Patellar tendon and the Achilles tendon. Jill is so knowledgeable. I learned a ton throughout this 45-minute podcast. Hope you guys take some stuff with you from this podcast. All right, enjoy.
The Prehab audio experience will teach you how to take control of your health through knowledge by optimizing performance, promoting longevity, and keeping your movement system in tune. Welcome to your host, the Prehab Guys.
All right, today we have Dr. Jill Cook, the tendon expert herself. I've been waiting for this one for a few weeks. I know a few of you guys have had multiple questions on tendon issues, and I think we have the perfect guest here today to tell us more about tendons. But first, I wanted you to introduce yourself, Jill, and tell me a little bit more about how you got to where you are today in terms of being at the forefront of tendon pathologies.
Thanks for the opportunity to be here. I was a clinical physiotherapist for many years and worked with basketball, and I had a lot of my players who had tendon problems, particularly the patellar tendon, and I wanted to know what the best options were for treating these people. And when I went to look for what the best options were in the literature, there was really nothing there. And so started to do some really poor research, and then was very fortunately picked up by Karim Khan as my supervisor and completed my PhD in patellar tendinopathy, and it's sort of gone from there. And I'm pretty chuffed with how much progression we've made in the management of tendinopathy since I started in the early 90s looking for these solutions.
Yeah, awesome. And now are you focused more on the research aspect of things?
I have always kept a clinical footprint.
Mm-hmm.
I think it's really, really important to still see patients with tendon problems, because otherwise you end up thinking you know, and the answer is you don't, because there's always someone out there with something different. So we run what we call the desperate and dateless clinic, and in it we see people who have either long-term tendon pain or really recalcitrant and nasty tendon problems. And that keeps us on our toes in terms of really trying to work through not only the simple solutions, but how we manage the more complex presentations.
Makes sense. Love it. So let's go into the tendinopathies that we commonly know about. And where we can start with, I think, is just a basic understanding of the tendon continuum or tendon pathology continuum. And I know historically we've thought, oh, these tendon issues are all an inflammatory response or just a change in collagen matrix, which it doesn't seem to be the same as we originally thought. And I think you've helped kind of show this through a lot of the research that you've done. Can you explain a little bit more about, I guess, where the original thought was and how we've progressed and where we are today in terms of understanding this tendon continuum?
Yeah. So when I started managing tendons in a basketball population, it was inflammatory or thought to be inflammatory. And the frustration for me is we used all our anti-inflammatory treatments, which is rest, ice, anti-inflammatory medication, and we got absolutely no one better. And that was about the time where there was some literature on the pathology being what was then called degenerative changes within the tendon. And so that sparked our interest. Then, you know, the next sort of hurdle we faced was that it was a collagen tearing issue, so that if you overloaded your tendon, your collagen tore. And again, when you went back to the literature and looked, it's pretty impossible to tear normal collagen. You can't actually damage your collagen. It's so strong that you have to damage your muscle tendon junction or your bone long time before you actually hurt the tendon. And then in collaboration with Craig Purdom, who worked at the AIS, the Australian Institute of Sport, he saw a very young population. I saw a sort of a slightly older population and a combination of elite and recreational athletes. We sort of put together, there were actually different stages of tendon presentations, and that's how the continuum started. And we're still developing that. But I think the key thing is tendon pathology is about load on the tendon. So the more you load the tendon, the more likely you are to have tendon pathology. And it tends to be cumulative over time. So if you're sedentary all your life, you'll get to your 80s without tendon pathology. If you have a very active life where you put really high loads on your tendon, you can have pathology very early in your life. So the cumulative load perspective fits very nicely with the continuum model in terms of the progressive changes in the tendon over time.
Mm-hmm. Yeah. And I mean, I've seen that too with an acute increase in activity. That's that idea behind when the external demand exceeds your tissue capacity. That's when pathology occurs. And oftentimes I've seen it where the weekend warrior comes back and tries to play basketball the way they used to 5-10 years ago. However, their body doesn't have that capacity, and they haven't trained their body to load in such manner for many years. And when they get back onto the courts, that's when this issue becomes prevalent.
Yeah, the issue really is, you're right, a complete imbalance between the capacity of the tendon and the load that's placed on it. But what that initiates is pain. So the pathology can be initiated many, many years earlier and be asymptomatic for a long period of time. So pathology in the tendon doesn't always give you pain. When you overload a tendon beyond its capacity, that's when you will stimulate a pain response, and that's what brings people to a clinic for treatment. And the other thing I want to highlight is that when we talk about capacity, we often talk about capacity in the tendon, and what we're talking about there is how stiff the tendon is, because it's used like a spring. But I want to highlight that the capacity in the muscle, so the muscle strength and endurance, the capacity in the kinetic chain, so that's all the other joints and muscles that contribute to your ability to jump and change direction, and the capacity in your brain, so that's the motor drive to the muscles, are all affected by tendon pain and all lose capacity when you unload. So it's a loss of capacity that's important, and we know it exists in the tendon, but I want to highlight that we actually have to be quite holistic in our rehabilitation, not only to deal with the tendon, but to deal with the muscle, the kinetic chain, and the brain as well.
Yeah, I think you brought up a few good points. And actually, I just had an interesting thought. If, like you were saying, the tear is usually the myotendinous, basically where the muscle inserts onto tendon, or when the tendon inserts onto the bone, it seems like, for the most part. However, Achilles tendon seems to be the only tendon, at least that I've read, where there can be a mid portion or in the middle of the tendon that can actually become pathological. And we can talk about the difference between pathology and pain, because I think that's a very good point that you hit on. But in terms of this mid portion Achilles tendinopathy, do you have any speculation or theories as to why maybe the Achilles is the only one that we see that mid portion pain?
Yep. So just covering off on some of your comments, pathology at the muscle tendon junction is a muscle strain. So that's a completely different condition from a tendinopathy. So we see that with an acute overload, you go to change direction, you tear your calf. That's a muscle tendon injury, junction injury, and that's not what we're talking about today. The other end, the bone tendon junction, you're right. It is by far our most common presentation, and virtually all tendons, except for the mid-Achilles, as you say, the pathology occurs at the bone tendon junction. Now, some people might comment now about tib post, because that occurs in the mid-tendon, but the difference between that and the Achilles is that the tib post is compressed as it goes around the malleolus. So it comes back to the type of loads that are placed on the tendon, and there are two loads that are really, really important for a tendon in terms of inducing pathology. The first is our energy storage and release loads. So that's our spring-like loads. So that's the jumping, change of direction, all of those sorts of things. And the second load is compressive loads. Now that occurs at the bone tendon junction in virtually every tendon. And the combination of compression and tensile loads been shown to be the most provocative for tendons. So if you just have compression, you don't tend to get into much trouble. If you do spring-like loads, you can get pathology. If you have the combination, you get into a lot of trouble in terms of tendon pathology. Now, the reason that the tib post and the perineals fail at the point of compression is exactly that. That's the point where they're energy storage plus they have compression. The Achilles is a little bit different. It's probably our biggest spring. And most of our other tendon springs are relatively short. The amount of energy they can store is relatively low. But the Achilles tendon works as a massive spring, and the amount of load that you place on it when you jump and change direction is enormous. And so I think that's probably mostly spring-like loads, although there's some evidence that there can be compression from an associated plantaris and stuff like that. But I think it's just exposed to such big energy storage loads. Whereas the other tendons, they're smaller, they're short, they store energy, but they don't get into as much trouble from a tensile load perspective.
Interesting. So would you say that since the tendons have such a large energy storing capacity, in order to prehab or to allow for maximal capacity of the tendon, you need to train it in such manner where just heavy, slow resistance training is not enough? Meaning if you want to go play basketball, and like you're saying, you're basketball athletes, you want to make sure they're at the top of their game and they're at the minimal amount of risk for injury. You need to train them in such manner. Just heavy strengthening is not enough to load that tendon appropriately.
Yes, I would. I think the 2 points with that is you can't just do the faster plyometric energy storage loads. You can't. If you try and do that prior to having adequate strength in the muscle and mechanical strength in the tendon, and you get that with your heavy, slow resistance loads, and it also allows you to improve the function of the kinetic chain, function of the brain. So that heavy, slow resistance phase is critical in setting a base so that when you go on to these faster loads and these energy storage and release loads, you actually have a capacity within the muscle tendon unit, the kinetic chain, the brain to actually tolerate those loads. So you can't just do that. In fact, that's when people fail. People come to you when they're running, jumping, changing direction, and their tendon is painful. And if you said, well, let's rehab you with running, jumping, and changing direction, they'd look at you quite strangely. What is happening is that tendon is not ready or capable of taking those loads. So you've got to actually change something before you go back to those loads. And that's the heavy, slow resistance part. Massive effects on the muscle, the tendon, kinetic chain, brain, essential as a start point for rehabilitation. And if you're trying to maintain somebody on the court in season, you can never, ever let go of heavy, slow resistance. It's such an essential part of trying to maintain function while someone's continuing to train and play.
Would you, let's say that athlete's in season, would you purposely avoid eccentrics, or would you want to do it all to load the muscle and tendon mechanically and create some mechanical damage to the muscle?
We would never load eccentrics in isolation. I think eccentrics are an important part of heavy, slow resistance, and eccentrics are an important part of the spring-like loads that you need, or the base that you need to put the spring-like loads on the muscle tendon unit. But isolating it out is not really that helpful for us. And we would never use them just as a one-way thing, unless you are really struggling to get your heavy, slow resistance, but you don't in tendons. Remembering that to get energy storage loads on a tendon, it has to be a fast movement, otherwise the tendon spring won't work. So anything slow is easy for a tendon. In fact, anything slow and heavy is actually beneficial for a tendon. So you don't have to change how you would normally do a heavy slow resistance to isolate out the eccentrics. You get that as part of the program.
Mm-hmm. That makes sense. Now, let's say someone comes into the clinic and they have this Achilles tendon pain, which, as we mentioned before, pain and pathology are they don't necessarily go hand in hand. That pathology may have been there previously, or maybe there isn't even a pathology, but the pain is present, right?
Mm-hmm.
A good starting spot seems to be isometrics, and I've heard you talk about why that may be beneficial initially. Can you talk a little bit more about why you think that's like a safe starting point for most people that do have pain in their tendons?
Okay, so just again to pick up on a couple of points that you made, if the tendon is normal, that is on imaging, and you have pain, then the tendon is not the source of your pain. So you can't get tendon pain unless you have pathology within your tendon. So it's a really good differential diagnosis, and it's really important that the clinicians out there realise that normal tendons can't give you pain. So that's the first thing. What happens then is that once you have a painful tendon, that it causes unloading, and then you get all sorts of muscle changes, you get kinetic chain changes, you get brain changes, as we know. And so it becomes a bit of a vicious circle. You see, pain causes you to unload, your unloading causes changes in all of those structures, that then makes pain more likely and worse, and down you go in a spiral. We've never had anything that's been able to change pain in the short term. We've always known that getting people on a strength program will help them in a period of 4 to 6 weeks. But we started to look at isometrics quite a few years ago as a way of getting some load on very painful tendons where we really struggled to be able to do much with them. And what we found is we got massive benefits from it. And so we started to do some research on it. What we know from our research and what we know from clinical experience is that isometrics can give you an immediate and sustained relief from tendon pain, and it's fabulous in people who are still trying to compete, but it's fabulous in people who are in the rehabilitation phase because it allows them to do more things. Why isometrics work, we're unsure. We know that it changes cortical inhibition. We know that it probably changes something in the tendon, but we actually don't know why it changes pain. But what I would love to emphasise here is we see a lot of people who come to see us with their tendon pain and say, well, I've tried isometrics and they didn't work. And the answer is probably 19 times out of 20. Either they don't have tendon pain in the first place, they've been diagnosed as tendon pain and they don't have it. It's very common. But if it is tendon pain, then the isometrics haven't been done correctly. And what we did in Ebony Rio's research, where we showed this sustained, immediate and sustained benefit from isometrics, was Ebony did 18 months of pilot testing before we settled on that protocol. Now, what she found was that short time loads, so holding for less than about 30 seconds was not beneficial, and low loads were not beneficial. So if you're going to get a benefit from isometrics, it's got to be heavy for the person and for the muscle and the tendon, and it's got to be quite a sustained hold, and you've got to do your 5 repetitions. So nearly everyone who says isometrics don't help tendons actually isn't doing them correctly, or they're doing them in a patient that doesn't have tendon pain. Despite all my Twitter fights with people, really I would stick to that as my baseline, and we get excellent results in people with tendon pain with heavy, long hold isometrics, and it's empowering for patients. They can take these very simple exercises home with them if they're going for a run or they're going out somewhere or going for a walk with the dog and they want to relieve their Achilles tendon pain. They can do the isometric exercises, get benefits for sometimes 4 to 8 hours, and it allows them to live with their tendon pain while you rehabilitate it.
That seems like a possible good way of using a diagnostic technique as well, to just load up the tendon and see if the pain starts to become a little bit lessened with just an isometric load. Would you agree with that?
Absolutely. If we can get in some of our more complex patients to the end of a subject or a history and an objective examination and still not be absolutely sure how much of the pain is from the tendon and how much of the pain is from other structures, what we will then do is do an isometric protocol properly, and we expect the tendon pain to drop by half. So we do a provocation test. So say for the Achilles, we might do a hop test. We'll do the isometric protocol and then re-hop them immediately. We want to see at least half the pain or less. If we don't see that, then we immediately start to think about some other structure contributing to the pain as the major contribution.
So the protocol itself was it 45 seconds on for 5 rounds, 70% of max
MVC, yep, and with a good 2 minutes between to allow recovery. So you don't want people to get a fatigue in the muscle and in the sort of motor drive. So giving them a good break between each repetition is really important. I think you have to aim for that. But clinically, how we do that, the 70% MIVC is really hard for people. What we look for is the load that they can sustain well for 45 seconds. So if we put a load on them and at 30 seconds they're getting some, muscle shake, muscle fatigue, perturbation, can't hold it, it's too heavy. If they get to 45 seconds and they're thinking about their chicken dinner tonight, then it's too light. So what you want is a load where they can make 45 seconds, but it's a pretty good task for them. And that's seems to sort of correlate for us clinically anyway, with about 70% MIVC. So you've got to play around with your loads to make sure you get it about right for these people.
And then in terms of what position you'd put their ankle at, is there a specific range of motion that, let's say for that Achilles tendinopathy example that you were giving, do you want it towards mid-range, more towards end range? What are you thinking with that?
It depends on what you're dealing with in terms of your Achilles. So if you have an insertional Achilles or a plantaris-associated mid-Achilles, then you can't be near dorsiflexion because that's a point of compression. So you need to be quite a lot higher. And so you would go as high as you needed for them to be able to complete the exercise pain-free. If it's a standard mid-Achilles and you don't think there's any compressive issues happening, then towards dorsiflexion is better, because the more you go towards dorsiflexion, the higher the load on the tendon. So we tend not to go over the edge of the step in the initial phases at least, but we would be, 10 or 20 degrees of plantar flexion, so relatively low for a standard mid-Achilles. But your differential diagnosis here is really important, because if you have a plantaris-associated mid-Achilles, then putting them towards dorsiflexion is going to actually make them worse. So you have to be sure with what you're dealing with first.
And then do you feel like someone's body weight is typically enough for this 70% MVIC, or do you feel like someone typically, most of the people that you've seen typically need to have an external load to assist in putting extra load on there?
Yeah, so tendon pain is really interesting. It drives unloading more than any other pain I know. And so people very, very quickly become quite weak and unable to even do a reasonable calf raise. So even in elite athletes, we've seen who are training and playing and able to do many things, can't sustain a single leg 45-second contraction. So it is mostly enough, but occasionally, obviously, you need more. And there are a lot of our older, more sedentary people who can't go single leg, who actually have to start double leg. And we do have people who can't even sustain body weight loads. So we'll actually go with a seated calf raise, where we take the body weight loads off them and actually control the amount of weight on the tendon, down around 5, 10, maybe even 15 kilos. So you can go right from that level up to our better athletes can sustain an isometric contraction with their body weight plus their body weight on a bar. So, the Achilles is quite hard because you actually have to hit exactly, well, not exactly, you have to be in the ballpark of getting the load right. If you're too low, you're not going to be effective. If you're too heavy, you're going to upset them. So you have to actually become quite skilled at exercise prescription.
Would you say the same thing for patellar tendinopathies, where people are hesitant to load onto those areas, even if they do have that strength? They have a little bit of cortical inhibition going on.
Yeah, patellar tendinopathy is easy, not easy, because it's a condition of young jumping men. Okay, of all the people with patellar tendinopathy we get sent in the desperate and dateless clinic, I would think close to 70% have patellofemoral pain, with pain referring into and around the tendon. So it pretty much only exists in elite jumping men, basically. So it's easy in those people because they need to be in the gym, and you would do a leg extension with it. It's so simple, with as much weight as they can hold for 45 seconds. So there's no issues with getting those people to load. The issue around the patellar tendon is making sure you're actually dealing with a tendinopathy. And the more people we see, the more we realise that this is horribly misdiagnosed and it's much less common than what people think.
Interesting. Yeah, no, that makes sense. I feel like patellofemoral pain syndrome in general is just such an umbrella term that it encompasses a lot of what we see in this patella tendon issue. May be overdiagnosed because really with heavy isometric contractions, these tendon issues should start feeling better. And that's a good way, again, to differentiate between the two.
Absolutely. So we would do two things. If at the end of our subjective and objective examination we still weren't sure, if we think it's tendon, we'll go with an isometric intervention and expect that pain change. If we think it's patellofemoral, we'll do the McConnell diamond taping and retest. And if we get a change in pain by half or more, then we'll go with a patellofemoral diagnosis. But I'd really like to highlight it's really commonly patellofemoral pain, not patellar tendon. And outside of young jumping men and very, very occasionally very elite young jumping women, patellar tendinopathy doesn't exist as a diagnosis.
Then in these tendon issues, do you feel like there's even a need to give someone a period of even temporary immobilization, or is it kind of load within someone's tolerance as soon as possible and see how they feel?
I would say never rest a tendon, never. And you can always do isometrics. You can actually almost always immediately do heavy, slow loads because it doesn't affect tendons. Tendons love heavy, slow loading. And when I say heavy, everybody's thinking I'm talking about 60 or 70 kilos. I'm talking about heavy for the person. Mm-hmm. So it might be 2 kilos or it might be 10 or it might be something else. But slow loading for tendons is not provocative and you can always get some load on the tendon. If you immobilize or rest or do any of those things, you just continue to lose capacity in the tendon, the muscle, the kinetic chain, the brain. You're actually just making things worse. Taking time to recover from the rest time is one of our biggest challenges. We can see people who have been unloaded for 12 weeks. Well, we immediately know that that's at least a 3 or 6 month rehabilitation because we're undoing what we've lost in 3 months of unloading. So I could not advocate more for never resting a tendon completely. You can always find a load that they can take.
Mm-hmm. The more I think about it, the more I realize, because I've been using blood flow restriction training in my practice pretty recently within the last year or two. And with these tendon issues, it seems like that's actually not beneficial and you're doing a little bit of a disservice because you want to go heavier than this 20 to 30% of someone's 1RM. And for most acute patients I see, I do use BFR, but tendon issues seem to be one of those things that we don't want to use BFR and light load. We want to load heavy.
I could not agree more. And it's, again, one of these bandwagons we all jump on. But what we know changes the mechanical properties of the tendon is heavy, slow resistance and isometric loads. So if you do BFR and you get some muscle changes with lower loads, you're actually not helping the tendon at all. So, in fact, you actually have to get the heavy loads on the tendon. and you'll get the benefits in the muscle as well. And the second thing is that heavy, slow resistance training for tendons isn't painful. So for patellofemoral joint pain, I really understand it, because, you know, you sometimes can't load heavier because of pain. We don't have pain with heavy, slow resistance in tendons. So pain's not a reason to do it either. And we don't know what effect it has on the brain in terms of changing the inhibition and the motor drive. Research to be done there. But I would advocate that you have to get the load on the tendon and the muscle in people with tendon pain. Otherwise, you're not going to be successful.
Is there any, with patellar tendinopathies, is there any other way to get this heavy, slow resistance training aside from leg extension that you'd recommend?
The only other thing that is slightly effective, actually, no, that's not true. It's really effective, is the Spanish squat, the reverse squat with the belt, where you tie the belt around some sort of structural thing and you hook it around each leg and you sit backwards. That can be really, really effective and very good for people who can't access gym work. Wall squats are a waste of time. Please do those. They don't help us at all. Leg press can be a good exercise because it does include the kinetic chain. But remembering, if we're talking about who gets patellar tendon problems, it's young jumping men. They need to be in the gym because they want to jump high and a lot. So you can't get the strength and capacity you need in any of your structures without that heavy load. So we can in the Achilles, we can in the hamstring, we can in the glutes, and a lot of other tendons we can do it without the gym. In patellar tendon, we can't. And you're fooling yourself if you think that you will return somebody with a patellar tendon problem, if you've diagnosed it correctly, back to sport without some gym-based exercise.
And then in terms of same thing with the patellar tendon issue, right? Versus when you talked about the Achilles tendon, there's the reactive phase that is when someone actually has pain, and that's that area. So someone can be degenerated without pain. That means they have this tendinopathy, or someone can be just reactive. So there's degenerated with a reactive tendon and then just a reactive tendon, correct? Can you explain the difference between?
Yes, certainly. So the process of the continuum is a reactive tendon, and we've got some new ideas around that I won't share with you today. So that's the early stage of pathology. And then disrepair and degeneration, you get a progressive disruption of the tendon matrix. Degeneration by itself is not painful. So if we went out into the community with our ultrasound or MRI machine, we'd find a lot of people with degenerative tendons that just don't have symptoms. What happens is when you overload that tendon, the degeneration doesn't take any load because it can't, because it has no structure. So all of the load goes through the normal part of the tendon that's remaining, and you get a reactive change in that. So that's called reactive on degenerative. That's by far our most common presentation. Nearly everybody that you see, even young athletes, can have reactive on degenerative changes. The reactive stage, which exists prior to any sort of profound change in the tendon, is often quiescent. You often don't know it happens. And so they don't present, because if you get reactive change in the middle of your tendon, you often don't get any pain signal because your peripheral part of the tendon is the innervated part. So you can actually go through a whole reactive stage and not actually know you've done it. When we see it clinically, it's when you've had a massive reaction. And an example would be, tends to happen in younger athletes. So someone who trains 2 or 3 times a week goes into some sort of elite environment and trains 3 times a day for a week. So you have this profound overload. Tendon gets really unhappy with that rapid and massive change in loads, and it becomes very painful, very swollen, and truly reactive. And we see it, probably the best example is we see it in horses that get an acute bowing in tendon. The other way you can get an acute reactive tendon at any age is if somebody actually compresses your tendon acutely. So someone runs into the back of your heel with a trolley, or you hit your elbow, or you fall on a stone and hit your knee tendon. So an acute compressive load can create a reactive tendon. And I don't know if anybody's experienced that in your audience or seen it as a clinician. They're horrible tendons to get better because they actually are a true compressive induced reactive tendon. So we see the true reactive in younger people with an acute overload. They're sore, they take ages to settle, a couple of months to settle. An acute compressive load, sore in any age group are very hard to settle, often months to settle. And then our degenerative and reactive on degenerative, our degenerative ones aren't painful. Our reactive on degenerative are in older people who've done some sort of overload and the tendons got sore to a greater or lesser extent. They tend to settle relatively quickly. So within 7 to 10 days, if you're careful with the load, the whole thing starts to come down. So they're quite a different clinical presentation.
Would you say that the 7 to 10 days partially is because they're not getting back to this extremely high level of function, or it's just the pain response that subsides?
Yeah, no. As soon as you unload a tendon, it's as happy as it's happy. So what acute onset of pain does to you is it stops your loading. So you think about going for a run, you think, no, I don't think my Achilles is going to really like that. And so you get very, very quickly, you change the loads on your tendon. Now, you'll do that without clinical advice. But if it persists, you'll go and see a clinician and they'll tell you to rest. And, of course, then it will continue to get, your pain will continue to come down. So it's the body being pretty smart. And tendon pain's quite unique. So if, for example, you have back pain, it sometimes hurts when you bend over, it sometimes doesn't, it sometimes hurts when you sit, it sometimes doesn't. So your brain's quite confused about the link between load and pain. In tendons, the link between load and pain is so clear. You load it, it hurts. And so your brain says, right, that's simple, I'm not going to load it. And so we see massive changes in people with tendon pain because of this direct connection between load and pain.
And then the subsequent pain after load can sometimes be a little delayed, it sounds like, with tendons, right?
Yes. So the best, yes, that's right. The best response, we never worry about pain during exercises when we're rehabilitating someone. And in our subjective history, we always ask, if you do activity today, when are you worst? And people with non-tendon pain will say, I get worse during activity and I'm bad after activity. People with tendon pain will say, I warm up with activity and then I'm a bit sore afterwards, but the next day it's a disaster. I can't get up and down stairs, I'm stiff in the morning, all of it. I can't sit on a chair, all of the things that we classically see. So that's a really important discriminator, particularly in and around the knee, as to when your load provokes your most pain. For tendons, it's always a 24-hour response.
Interesting, because I could imagine how you have a patient and they're in the reactive phase, you load them and it feels better temporarily. Maybe it's a little bit too much and the next day they feel a little bit painful. Now we're worried about pushing them to this disrepair and degenerative phase, right? And so we want to make sure to load them within their tolerance. Would you say that's a little bit too much load if they have that adverse effect afterwards?
Yeah, so we're looking for stable pain or less pain the next day. So the critical thing is that pain is not more. Now, we're not looking for it to be 0 the next day. So if somebody has a 5 out of 10 pain and we load them and tomorrow morning it's 5 out of 10 pain, then we're going to say that tendon has tolerated that load. But if it's 5 out of 10 pain and we load it and tomorrow it's 8 out of 10 pain, then that's too much. So I think people get caught with the fact that, load, you should have no pain the next day. If we've waited for our athletes to have 0 pain, we'd never get anybody back to any sort of loading. We're looking for a completely capable tendon, muscle, kinetic chain brain that can perform at the level the person wants with stable pain, where they know their tendon, they know what they can do, they know what they can't do. Tendon's very happy. It's an algorithm of incorporating the tendon and what the person needs and what level of performance they're at to come up with those decisions. But a lot of people, certainly our sedentary, more recreational people, we can get rid of pain completely. But, tendon, once a tendon, always a tendon. If you can get rid of tendon pain, but if you're stupid, it'll come back. And it won't go away forever. People often have to learn the fact that, that they can rehabilitate a tendon, then they'll stop going to the gym, they'll stop, doing things, they'll start to do silly things, their tendon pain will come back. I'll come and see you again. You'll say, well, what were you expecting? You know, I told you how to look after this tendon. To do it for the rest of your life. This is not something that you can just ignore in the long term. And it doesn't take much to maintain tendon capacity, but people have to learn that.
Yeah. And obviously intensity and frequency are inversely related. At first, we're shooting for, it sounds like, having this routine be done daily. And as they progress, maybe they're pain-free. Would you say once they're in this plyometric phase where they can jump and load pain-free, it's more towards 2 to 3 times per week? And what's like the minimal effective dose, I guess, for maintaining optimal tendon health for somebody?
Yeah, the energy storage and release loads are the highest load on the tendon. There's no doubt about that. And particularly if you add the compression as well. So, you know, you can pick out the activities that are going to do maximum load. It's a very resilient tendon that can do that day after day after day. And I think there are athletes out there who can do big track sessions every day. But when you're recovering from a tendon problem, or you have a tendon problem that comes back again and again and again, then those sorts of activities do have to be day on, day off. So you have to be quite strategic in how you do your training. So you can often get 3 or 4 good sessions a week out of it, but within those sessions you might manage how many sprinting or change of direction drills you do. You know, so you can micromanage down to any sort of level that you want. The critical thing is that you can never let your strength work, your heavy, slow resistance go. And so often we are having a stimulus on this tendon where we might do a training day, then a strength day, and a training day and a strength day, and then a competition day and a day off, and then a training day and a strength day, so that we always keep those loads mixed on the tendon, but maintaining strength and mechanical properties within the tendon is absolutely critical.
Interesting. Awesome. So as you know, we're the prehab guys, and we're trying to preach injury prevention, and by that, mitigating risk of future injuries. Is there any big piece of advice you'd recommend to our following in terms of maintaining optimal tendon health? You kind of hit on this with this answer that you just gave, but is there anything else in terms of what they can be doing on a weekly basis, or how they can program themselves to keep their tendons resilient?
Okay, the simple answer is tendons don't like change. And so if you are going to be changing your training anyway, you have to sneak up on it with a tendon. You can't decide today to run a marathon tomorrow because something's going to fail. And often it may not be a tendon, it might be your bone or your muscle or something else. But tendons are particularly sensitive and slow to respond to load changes. So that would be my absolute advice, is plan any change in load and be considered about how you do it, and think about what you're asking your tendon to do. The second thing is, if you have a good strength base in the muscle and you maintain the strength in your kinetic chain, you are going to be much more load tolerant and much more able to change your load quickly, because you're not coming off a base where your tendon is exposed. If you don't have good strength, the tendon becomes exposed to quite aberrant loads as a spring. And so you need to stay strong. And I would advocate that for everybody. Now, strong doesn't mean in the gym pushing big weights every day. You know, for a recreational athlete, it's doing some decent calf raises twice a week at home, single leg. That might be sufficient. Or doing some bridging if you have a hamstring tendinopathy 2 times a week. That sort of stuff. So it doesn't have to be arduous, but it has to be considered. And what we see is people who often have a problem, you can rehabilitate them, they recover, they get a second problem, you know, and you say, well, what were you expecting, because you did this wrong and this wrong and this wrong, and you stopped your strength work. Third and fourth time, they either get it and they actually don't have a problem again, or, you know, these people are never going to learn, and you just taking their money. But you don't have to keep taking their money, because you can control your own tendon pain with some thoughtful work. And that's what we need to teach people.
Yeah, absolutely. You can't go wrong with getting strong.
You sure as heck cannot get wrong with getting strong, for whatever I said.
Yeah. All right, Jill, thank you so much for that. I know we talked about this briefly before. You have a Twitter, right, that people can follow you on?
Yes.
What's the handle for that?
At Prof. Jill Cook.
Perfect. Awesome. And anywhere else specifically that people can find you?
No, as I said, I'm a bit of a privacy nut, so I don't have any other social media. I'm obviously working at Trobe University, so you can find my profile, my email and all that sort of stuff there. But I struggle sometimes to really, particularly after podcasts like this, to respond to everybody's query. So try to, but sometimes it takes me a little bit of time. So please don't inundate me with emails. But I'm very happy. I always answer questions on Twitter if someone asks me something directly, and I try and respond to emails. But I can't solve your problem online. If you live in the US, I can't treat you in Australia. So,
Really?
But I'm happy to answer questions.
Yeah. Well, I mean, I learned a ton from this hour-long podcast that we did. I'm sure our audience did as well. Really appreciate you taking the time out of your busy schedule to sit down and talk to us about tendon pains and tendon pathologies. Really appreciate that. And thanks again for coming on.
My pleasure. Thanks for having me.
Hope you enjoyed this information-packed podcast. Jill Cook is full of knowledge, and I'd love to have her back to further unwrap some tendon issues. If you enjoyed this podcast, please rate or review this podcast. This helps us tremendously. Let us know what it is that you want to hear more of. Thanks for tuning in.